Hi there, this is Lieutenant Commander Kelly Trout, and today I'm going to talk about the anesthesia management of the obese patient. Obesity is based on body mass index. Greater than 24 is considered overweight, greater than 30 obese, and a BMI of greater than 40 is the definition of morbid obesity. Obesity-associated problems include type 2 diabetes, coronary artery disease, hypertension, obstructive sleep apnea, and osteoarthritis. The obesity-altered organ systems that anesthesia providers are concerned with is the respiratory system, cardiovascular, renal, hepatic, and drug metabolism and clearance. Obesity has physiological consequences on the respiratory system, such as increased oxygen demand, increased carbon dioxide production, and increased alveolar ventilation. This is due to an increase in the metabolic rate and is proportional to the amount of body weight. Excess thorax tissue decreases chest wall compliance, while lung compliance remains unchanged. The diaphragm is pushed cephalad by redundant adipose tissues of the chest wall, thereby decreasing lung volume similar to restrictive lung disease. The supine and trendelenburg positions further decrease the lung volumes, and the functional residual capacity, or FRC, may fall below closing volumes, causing some of the alveoli to collapse during normal ventilation, resulting in a VQ mismatch. Excess adipose tissue also deposits in the oropharyngeal spaces, causing an upper airway obstruction, and often leads to a difficult DL view, obstructive sleep apnea, and obesity hypoventilation syndrome. OSA is defined as 10 seconds or more of total respiratory cessation that occurs more than 30 times a night. Obesity hypoventilation syndrome is diagnosed where there is a BMI greater than 30 and an awake PaCO2 of greater than 45 without other causes of hypoventilation such as COPD. Both OSA and OHS are characterized by hypercapnia, cyanosis-induced polycythemia, daytime somnolence, and can lead to cor pulmonale. Long-term OSA and OHS patients have a blunted respiratory drive from the chronic upper airway obstruction and apneic periods, and there is thought that the OHS has to do with abnormalities in respiratory mechanics and central respiratory control. In the post-op setting, OSA necessitates the judicious use of opioids and sedatives due to the relaxation of the excessive oropharyngeal tissues that helps contribute to the upper airway obstruction. OSA has been associated with periop hypertension, hypoxia, arrhythmias, MI, stroke, and death. As blood volume and cardiac output increases with body weight, the heart's workload is increased, leading to left ventricle hypertrophy. This enlargement, combined with the hypertension often seen in obese patients, can lead to elevations in pulmonary blood flow and pulmonary vascular resistance from the persistent hypoxia, which can then lead to pulmonary hypertension and cor pulmonale. Increased renal blood flow and glomerular filtration rates leads to increased renal clearance of anesthetic drugs in the absence of renal pathologies. Drugs that are exclusively renally cleared, such as aminoglycoside antibiotics, may require increased dosing. Also, renal tubular reabsorption interferes with sodium excretion via the sympathetic activation of the RAS system and helps contribute to the hypervolemia of hypertension. Abnormal liver function tests, such as elevated alanine aminotransferase, or ALT, is common in up to 1/3 of all obese patients, but drug clearance and phase 1 drug metabolism is usually not affected. By contrast, phase 2 drug metabolism is enhanced. Obese patients are at an increased risk of non-alcoholic fatty liver disease and cirrhosis, which can ultimately affect metabolism and clearance. Gastric volumes in obese patients that have fasted for surgery can exceed 25 milliliters and have a pH of less than 2.5, which puts them at greater risk of pneumonitis if aspiration occurs. Gastric emptying is delayed due to increased abdominal tissue and a decreased pH. The weight of the excessive abdominal tissue also reduces lower esophageal sphincter tone. For these reasons, an obese patient is at risk for gastroesophageal reflux disease. A real quick review on volume of distribution. Remember that VD quantifies the extent of drug distribution, or in other words, it's the overall capacity of tissues versus capacity of blood for the drug. The VD in obese patients are affected by a decrease in total body water, an increase in total body fat, lean body mass, blood volume and cardiac output, increased blood concentration of free fatty acids, triglycerides, cholesterol, and alpha-1 acid glycoprotein, as well as how lipophilic a drug is. In regards to the increase in total body fat, an increased distribution of a lipophilic drug will prolong its elimination half-life even when clearance is unchanged or increased. There is more storage space for the drug. Hyperlipidemia and increased amounts of alpha-1 acid glycoproteins may affect protein binding and decrease the amount of free drug concentration. However, plasma albumin and total plasma protein concentration binding are not affected by obesity. When determining how to dose anesthetic drugs for obese patients, look to the volume of distribution when calculating the loading dose. This means an obese patient has a higher VD or storage space for the drug. This will decrease the drug concentration in the blood and keep the drug from its intended purpose. Once you have a steady state of drug between the tissue and blood, how do you maintain it? Clearance of a drug has to be factored into the equation when trying to determine a maintenance dose. The body mass index is a measure for human body shape based on an individual's mass and height. Total body weight is how much someone actually weighs when they step on a scale. Most anesthetic drugs are based on either total body weight or lean body weight. The ideal body weight, based upon Broca's index, is the weight associated with the lowest mortality rate for a given height and gender. The lean body weight is the total body weight minus the adipose tissue and is calculated by adding 20 to 40% to the ideal body weight. For determining an initial loading dose, drugs like fentanyl, rocuronium, and becuronium that distribute solely to lean tissues should be dosed by lean body weight. Drugs like succinylcholine and dexmedetomidine that evenly distribute between lean and adipose tissues should be dosed by total body weight. As we discussed earlier in the presentation, clearance has to be factored in when calculating a drug's maintenance dose. If obesity affects clearance, dose the drug based on total body weight. If obesity does not affect the drug's clearance, base the maintenance dose on lean body weight. Highly lipophilic drugs like benzodiazepines and dexmedetomidine have a longer elimination half-life due to the increase in the volume of distribution in obese patients and are based on total body weight. The volume of the central compartment in which drugs initially distribute to is unchanged by obesity. So while the induction dose of thiopental is based on lean body weight, the maintenance dose is based on total body weight due to the increased volume of distribution. Propofol, while very lipophilic, has a high clearance rate. So while the induction dose is based on lean body weight, the maintenance dose is based on total body weight to keep up with the steady total clearance rate. Hydrophilic drugs, such as Vec and Roc, have a small VD, so obesity does not really affect their dosages, and they are based on lean body weight instead of total body weight to avoid a prolonged duration of action. Atracurium and cis-atracurium are not affected by obesity due to the organ-dependent metabolism and elimination. Succinylcholine is based on total body weight due to the increased plasma cholinesterase activity that is linear with increasing BMI. When conducting a pre-op evaluation on an obese patient, focus on the systems that will have the most effect on the anesthetic plan. On an ECG, you might see right ventricular hypertrophy as tall precordial R waves and/or a right axis deviation. Left ventricular hypertrophy, which impairs cardiac contractility, can be seen as a left axis shift and a prolonged PR and QRS complex. Pulmonary hypertension is fairly common with obese patients who have OSA and OHS. The patient might complain of exertional dyspnea, fatigue, and syncope during the pre-op eval and tricuspid regurg on ECG, which is the most helpful way of diagnosing pulmonary hypertension. Does the patient have chest pain at rest or with activity? Is the surgery elective or urgent? Can the pending surgery wait until the patient is optimized, are all questions anesthesia providers should be asking themselves when dealing with an obese patient. According to a 2012 review article by Domi and Lahu, 40 to 90% of obese patients have OSA. The stop bang tool is useful in determining if the patient has an increased risk of OSA. By simply asking questions about snoring, tiredness, observed apnea, and high blood pressure, you can get some insight if the patient might suffer from OSA, even if not formally diagnosed. Other risk factors of OSA is a BMI greater than 35, age greater than 50, neck circumference greater than 40 centimeters, and male gender. If the patient has been diagnosed with OSA, have them bring their CPAP machines from home to use during their PACU and hospital stays, as they are at an increased risk of post-op hypoxemia and hypoventilation. It is common to see abnormal liver tests in obese patients. However, in the absence of other hepatic disease, phase 2 drug metabolism is enhanced and hepatic clearance is usually not affected by obesity. BMI alone does not correlate with a difficult intubation, but can correlate with a difficult mask ventilation due to increased upper airway resistance, redundant supraglottic tissues, and poor chest wall compliance. Factors like Mallampati score of 3 or greater, history of OSA, increased age, male gender, and large neck circumference, in addition to an increased BMI, can predict a difficult intubation. In fact, Barash states that there is a 5% chance of a problematic intubation with a neck circumference of 40 centimeters compared to 35% chance of difficult intubation with a 60 centimeter neck circumference. Besides having to worry about blood sugars on an obese and diabetic patient, diabetes can also affect the airway by glycosylation of the cervical joint tissues, impeding flexion and extension. In regards to preoperative medications, consider dexmedetomidine instead of midazolam for anxiolysis and sedation to avoid respiratory depression. The potential for a full stomach could apply to the obese patient population, knowing that obesity slows down gastric emptying and reduces lower esophageal sphincter tone. Questions like, do you have reflux disease, and if so, are your symptoms controlled by the medications you take, if any, would be appropriate pre-op assessment questions when trying to establish an anesthetic plan. Inquiring about the last time a patient took their hypertensive and/or diabetes medication can help anticipate how rocky the anesthesia plan might be. Will the patient be hypertensive because they didn't take their beta blocker today, or is the intubated patient having refractory hypotension because they took their ACE or ARB that morning, are questions that the anesthesia provider should be asking themselves. So my initial 15 minutes is up. The remaining portion of this presentation can be seen in the second video clip.